Good morning, everyone. And for those of you who don't know me, my name is James Herbert Williams, and I'm the Dean here at the Graduate School of Social Work. And for those of you who are from the community, welcome to the campus at the University of Denver, and welcome to the Graduate School of Social Work. We're really pleased to have Dr. Kathol. Yeah, see, I was telling her I practiced on it all last night. Have Dr. Kathol here to share some of his practice wisdom and as well as his expertise in the area of care management. Dr. Kathol is a specialist in the care of patients with health complexities. Many of those who have concurrent general medical, mental health, and substance use disorders. He's a board-certified physician in internal medicine, psychiatry, and medical management, and with extensive clinical and administrative experience during his 22 years as a professor and a practitioner at the University of Iowa. He's also the president of Cartesian Solution, Inc., which is an organization that provides consultation and works a lot in the area of care management. For many of you know that in the last 3 or 4, 5 months or more, that Obamacare has put health care on the front of our agenda in this country. And whether or not if you love it or not love it, it's there. And we know that the Affordable Care Act is going to impact us. I thought it was very important that we would have someone of Dr. Kathol's expertise to come and talk about sort of what's going on in the area of health care. And so we're really pleased to have you here. So without further ado, Dr. Roger Kathol.
Thank you very much, Dean Williams, and it's a great pleasure. Thanks for inviting me here to share some thoughts with you on case management. And that's a term that has a variety of meanings, and I will take some time to define what I mean by that. But I have been working in the area of case management now for about, maybe 12 years or something like that. Started when I worked for Blue Cross of Minnesota. I was one of the medical directors for the case managers there. And since leaving them, I've consulted to a number of health plans, hospitals and clinics, large employers and government programs who are interested in integrating medical and mental health services. And case management fits right into that, and it really is going to be a major contributor in my way of thinking as we get into this Obamacare or the Affordable Care Act moving forward. So I'm going to be spending a fair amount of time setting the stage for why case managers are going to be a great contributors to this. But first I have to say that I do have a conflict of interest. I own a company that integrates medical and mental health services, so I am very interested in this. And frankly, I did both internal medicine and psychiatry because I wanted to take care of that orphan population that falls at the interface. And I did that for 22 years. I still do about a day a month of clinical work at Hennepin County, which is the county hospital in Minneapolis. But have largely gone into consulting to other healthcare organizations or health plans or businesses and et cetera. I also serve as the medical director and a board advisor for the Case Management Society of America, which is a membership organization of about 10,000 to 12,000 members. I think it's around 11,500 now, but they have a significant number that don't belong but use educational materials on their website and go to their meeting and et cetera. And it is about 85% nurses and about 15% social workers. The intent, frankly, is to bring social workers into that organization to a much greater extent. But they still are living in the traditional concept and are moving ahead with that. So I do have a connection with them, and probably more importantly, I've been working with them now for about 4 to 5 years in developing an approach to case management called integrated case management. And so I have a bias and I will share that bias with you as far as what I think brings value to the clients or patients or members, depending upon which group you're. Now, I will try to use clients because I know that social service uses clients mainly. You have to remember I'm a doc, so I use patients, and so if I slip, you'll know it's just because it's me. But then there's a lot of case managers that work at the health plan level, and they call them members, and they still are trying to provide improved service to people that are having difficult problems with health issues. So I'm going to start out with a sort of an upbeat challenge to you. Your role in the next generation of healthcare is to develop the vision and create the world. And I truly believe that. And social work actually has a huge place to play in this. There are way too few nurses to do all of the case management that's going to be needed in the future. And frankly, there are talents that you bring to the table that nurses do not as often possess as, now they would not, I mean, a lot of them do, but it's sort of the people issues that you can help them to learn some of the relationship issues rather than, the medical, do this, do this, do this, and they'll be fine. And you can learn from them in learning, some of the issues on the medical side as far as what needs to be done for patients or with patients to help them get better. So, but you have to be actively involved in this. This isn't something that somebody's going to come up to you and say, oh, come on, we need you to do this, and, oh, by the way, you do what we want you to do. You have to create the vision of what you do and how you bring value. So, there we go. Okay, so I'm going to start with patients or clients, okay? So Kurt is a 37-year-old gentleman who has morbid obesity, diabetes. His hemoglobin A1C is 12.2, which is way above normal. Normal is 7 or below. He has leg edema and foot ulcers, probably related to his poor diabetic control. He has retinopathy or eye disease related to his diabetes. He has kidney disease. And oh, by the way, he has depression as well. And in this world, that's a bad combination to have because it's difficult to treat diabetes when you have depression and you have difficulty having the energy just to follow through on taking your meds and et cetera. But in addition, he has a number of what I call non-clinical barriers to getting better. He's unemployed. He has no health insurance. He lives in a shelter. He has no car, so he can't get to appointments even if he wanted to. He doesn't trust doctors. He's stressed and frustrated. He eats too much, and he doesn't take his medicines. So he's really in a bad way. Now, the way that case management is done today, the clinical is the obligation of the mental health or the health professionals. Everything on the non-clinical side is his responsibility. And yet, the two really interact dramatically. So when you're unemployed, you have difficulty in, buying and taking medicines. You have difficulty in following through on care for your foot ulcers. You don't keep your diabetes under control, so your kidney and eye disease gets worse. And you feel bad because you don't have a job, and so it just makes your depression worse. No health insurance, you have difficulty in accessing clinicians and a variety of things. Lives in a shelter. Now that's better than living on the street because at least you have an address and you have a way of getting to a local community health resource, but it's still difficult if you live a fair distance and you don't have a car. And then, of course, he doesn't trust doctors because he's had so many different doctors, both regular doctors and student doctors, and he just sort of gets shuffled one from the next and never really gets a good longitudinal relationship going. And he's stressed and frustrated because he's trying, he wants to get better, but he just doesn't know how. And then, of course, he has broken family ties, and that just makes it more difficult for him as well. So the non-clinical and the clinical actually interact with each other. And that's where case management comes in. Now, let's talk a little bit about Angela. She's a 43-year-old with bipolar illness. She also has chemical dependence, periodic organic psychosis related to her intoxications. She has back pain and complaints. She has lung disease from her long-term smoking. She has hepatitis C and HIV related to her drug abuse. And, of course, multiple intoxications. And those are the clinical problems that Angela has. But she's unemployed. She doesn't have money for child support. She is on medical assistance. She's homeless with poor coping skills. She's not communicating. She has non-communicating clinicians, multiple drug-related arrests, and, of course, she has her alcohol and cocaine dependence. So she's got a problem, too, and one could say, well, the alcohol and cocaine dependence are medical/mental health issues. In fact, they are, but they're things that are oftentimes just neglected other than to take care of the acute intoxication and send her on her way. So both Kurt and Angela have real problems. They have both clinical and non-clinical problems. And frankly, clinicians live on the clinical side. They're not accountable nor responsible, nor do they see themselves as accountable or responsible for the non-clinical issues. And that is something that case managers really come into play on. So Kurt and Angela are examples of what I call complex patients. They have complex health needs. And you can see in this slide, there's a division, sort of patients or clients into three categories. There's the acute illness individuals who have acute problems, cold or pneumonia or GI flu or what have you, and those really account for about 85 to 90% of the total population. And they use about 1/6 of the health resources. 1/6 of the health resources. 1/6 of the health resources. So we have this huge population that almost use no medical resources, okay? Then there's the chronically ill or the seriously acutely ill patients, and they have things like diabetes or heart disease or renal disease or chronic lung disease, and they have difficulties in controlling their health needs. And they are really somewhere in the range of, maybe 15 to 20% of the population. And they account for about a third of total health resources, okay? So then you have this complex population which have multiple diagnoses. So they may have not just diabetes, but heart disease and kidney disease like Kurt or like Angela. And they have all of the social and personal ramifications of those that really create a perfect storm for poor outcomes. And so those are really somewhere in the range of 2 to 5% of the population, and they use half of healthcare resources. Now that population, those complex patients, are the population that case managers typically focus on. And that is a real opportunity not only to improve their health, but to decrease the total health care costs. And that's one of the reasons why I say that you all have a tremendous opportunity to contribute greatly in the future of health care. So Kurt and Angela really have some major health challenges. They have health issues that sap their energy. They have comorbid medical and mental health problems. They have clinical and non-clinical barriers to improvement. They have acute illness-related silos to get care in. So if you have mental health problems, you have to go to the mental health arena. If you have medical problems, you go to the medical arena. And heaven forbid that they should talk to each other. And believe me, I've worked in both arenas, and they don't like to talk to each other, don't get paid for it. They have many doctors, many needs, and a lack of understanding of how the health system works. So they're really in trouble. So the critical questions for case management outcomes are, who are the high-risk patients? Who are these complex patients that you really should target for the case management services? How do you identify them? What assistance should you give them and for how long? And what other factors play a role in this? What kind of training should you as case managers have? What background or experience do you need in order to address their needs? What should your caseload be? Caseload is huge. If you have too many cases, you can't do the things that are going to change outcomes. So you really have to match the caseload with the complexity level of the population you're serving. What protocols or guidelines should you use? How should you document? And then what about the patient-client and case manager relationship? How important is that? Turns out that that's a real important thing, and we'll talk a little bit about that. So I'm going to set the stage a little bit about our health system. And I give a number of talks both nationally and internationally, and frankly, this little graphic demonstrates how virtually all health systems in the world work. They have the purchasers, and it could be the government, or it could be employers, or individuals that purchase health coverage from fund distributors. In the United States, fund distributors are the health plans, or the third-party administrators. And you can see that the fund distributors are divided into the med, and that's about 96 to 98% of the total healthcare dollar. And that little MH over there in the corner of the triangle, that's the mental health. So that's somewhere between 2 and 4% of the total healthcare dollar. And it's that separation by the health plans to the providers. And the providers are not just you, the social workers and the docs and the nurses and et cetera. It's also the hospitals, the nursing homes, the residential facilities and et cetera. And you can see there the providers are now separated too, because they're paid separately. And that leads to separation of the head from the body. The patients are separated, or the clients are separated. So that really creates a problem for the clients. And yet, if you're going to be working with clients in the future, you really have to understand that the medical and the mental health problems interact, and the clinical and the non-clinical problems interact. And as case managers, you really need to learn how to assess and address the medical and the mental and the clinical and non-clinical in order to lead to outcome change. Now, you and the patient are there in the center, and all of those health facilities and personnel are on the outside, and so you really are the go-to person as a case manager to work with the patient. Now, the value that you bring is you have some sophistication about the health system. You understand a little bit about what residential facilities do, what community resources there are, what kind of things the hospitals do, how doctors talk to each other, and things of that nature. So you can really help them out to make sure that they don't get caught between the cracks. And you can see that the patient really is in the center of this, but the case manager is the one that's really talking to the clinicians, the facilities, the family and community resources, and et cetera, really supporting the patient. Now, as you work with the patient or the client, you're helping them to learn how to fend for themselves. So you're trying to move them to self-management. But so many of the people, as you start out working with them, are so needy that they really don't have the personal, the psychological, or even the medical resources to follow through on the things you know they really need to do. So you have to really be active with them for several weeks, if not months, before they really start taking charge of their own needs. So what is this case management? So case management, this is where we get really into the definition of care management is what I call the overriding term for management services. And management services mean helper functions. So you're assisting clients, patients, members, employees, enrollees, get the kind of services that are going to change outcomes. And under this care management, which is the overriding, which is clinical and non-clinical assistance to patients, clients by a health professional, such as social workers, as they attempt to improve health and function in a complicated medical system. It's mainly social workers and nurses that are involved in this. And I've talked to a couple of you already before the presentation, and I think that there's a perception that nurses are really heavily involved in this at the expense of social workers. In fact, social workers more often work on the mental health side and nurses on the medical side, and frankly, you should both be working on both sides. And you really need to learn some skills so that you can do that. And that's what this integrated case management program that CMSA, Case Management Society of America, and I have been involved in for the past 5 to 6 years. So now the overriding term is care management, but under that you have the low complexity kind of care management where you have wellness, health coaching, navigators. Employee assistance is a kind of low intensity care management. Then you have moderate complexity where you get into disability management or workers' comp, disease management, and occasionally disease management gets into high complexity because people with chronic illnesses obviously have problems that occur that make them more health needy. But the high complexity on the medical side is case management, and on the behavioral health side, it's case management too, but there's a sort of a subset of management called ACT, Assertive Treatment, Community Treatment, that really functions for chronic and persistently mentally ill, much like medical case managers do on the medical side for chronic comorbid medical patients. So the high complexity really is on both sides, and I'm going to suggest that there shouldn't be the separation of the medical and mental health, and that has to do with the interaction of the two. So case managers are distinguished from clinicians, and this is an important concept. Now, not all case managers don't give treatment. Some case managers do give treatment. Like there's a subset of case management called care coordination. It's a depression-focused case management, and the case managers in that provide problem-solving therapy to the clients as they go through that. But one of the reasons why we feel that social workers and nurses can do cross-disciplinary case management is because they are really directed to assist patients or clients get the kind of treatment that's going to be needed to change their health outcomes. And so they can do both the medical needs and the mental health needs because they're not giving, they're not prescribing meds, they're not giving therapy, they're helping the person get to the people that can actually change the medical and behavioral health needs. So the clinicians are the ones that treat, and that may be a social worker colleague of yours, an MSW that does therapy, and that's his or her primary job, or the psychologist, or it could be the nurse practitioner or the family doc or what have you. But the case manager is the one that makes sure that the person gets to the appointment, has money to buy their medicines, doesn't have a family member that's saying, treatment of depression is hocus, you don't want to do that, and, there's no follow-through on the recommendations by the clinician. So the case manager assists the patients in getting the kind of clinical and non-clinical assistance that they need in order to change outcomes. Now, one of the things that we do in this integrated case management, and in case management, traditional case management, we'll get to that in a minute, there is a focus on the biomedical needs of the patients, and biomedical are certainly an important component of complexity, but it could be that somebody isn't doing well because they don't have transportation to their appointments. So they use the emergency room as their primary care facility, and if they just had a family doc that could follow them, they could really be in better control. So that's a non-clinical issue. That's just getting to the doc's office. It has nothing to do with whether they got the right diagnosis or have the money to buy their medicines and things of that nature. So it's important for you to understand that non-clinical things can be as important or more important than clinical. Take a homeless person. Homeless people have tremendous difficulties in doing anything until they find a place to live. Okay, so the clinician's role in working with case managers, and you will be working with doctors and nurse clinicians and other clinicians that treat, is to make sure that they know how to use your services well, that they don't overwhelm you with the number of patients that you need to carry, that they discuss the cases and they coordinate their services with your services, and importantly, that you help them to understand when to escalate care, because you're going to be helping them to follow outcomes. And the patient or client is going to be telling you, how they're doing, and the doc may not ask that question or may sort of glance over it, and so there's no change in treatment, even though there's no improvement. Okay, and so escalating care is really a critical component. And then assisting the patient to get back to what I call standard care, and that's doing okay health-wise without your support. And it's real important that you learn how to graduate patients from case management, because you can't pick up more if you have this huge population you're already covering. Okay, so the case management responsibility is to identify and work with complex patients and to achieve the triple aim, and this is where the health reform issue comes in. The triple aim is to improve health, to improve the health care experience, how well the patient likes the way they're getting care, and, oh, by the way, lower cost. And if you're working with the complex patients that have this huge cost, you really have an opportunity of lowering cost as you help them get healthy. That's a win-win for everybody. So traditional case management is really biomedical, and it's both on the mental health side and the medical side, making sure that they get the right diagnosis or getting the right treatment, that they're taking the right meds and filling their prescriptions and things of that nature. And there's less interest in the non-clinical issues. And now, not completely none, but there's less interest in that. Most of the time in the traditional, there is a handoff from the medical case manager to the mental health case manager, or vice versa. And they don't talk to each other. You never know what happens once you throw them over the wall, okay, either way. And so that's a real problem for the patient. And it really shatters the relationship. The relationship really is a key component to change. And so you really would like to develop, maintain, and use that relationship to achieve change with the patient client. So case management programs that are currently in existence, and several of you already have told me that you work within some of these types, Guided Care, PACE, GRACE, Case Management Plus, are national recognized training programs for various kinds of case management. Of course, discharge management has many forms. Disease management, care coordination is this impact model that's mainly for depression. And they're moving now to working with the medical component of it. That's called team care, which is a real advance. Assertive community treatment, that's really mainly working with chronic and persistently mentally ill patients. And then pediatric is really interesting. What case management occurs in pediatrics really is taking an adult case management and saying, oh, well, these are just little adults. And that's clearly not the case. I know of no pediatric case management process available. There's CARES, which John Lyons has been promoting, and that's one of the things, but that's mainly mental health. It's mainly mental health. And so there are, in fact, we worked with John Lyons in developing the pediatric component of the integrated case management. And I'm not going to be spending a lot of time talking about that, but there's a huge need on the pediatric and adolescent age group for case management as well. So where are we today? Well, there was just recently a published report by the Agency for Health Quality and Research, which is a national agency for looking at randomized controlled trials and research. And what they did was reviewed the literature for medical services, medical case management services, and they were able to document that there is high evidence for no reduction in mortality or Medicare expenditures with case management. Now, they look specifically at medical case management and mainly outpatient medical case management, and they didn't really define what longitudinal range there was, but in the studies that they reviewed, which was 109 randomized controlled trials and over 100,000 patients, there's high evidence that traditional case management has that no reduction in mortality and expenditures. Moderate evidence that there's no reduction in problem behaviors, delay in nursing home placement, or rate of hospitalization. But there is moderate evidence for improved satisfaction, focused treatment adherence, and decreased caregiver depression, and selected improvement in diabetic and tuberculosis outcomes. So there are studies demonstrating that traditional case management can lead to improved outcomes for populations. That's the review of the main literature. Within that literature, there are a number of studies that are very informative about what can be achieved if case management is used in what I call an outcome-changing fashion. So I'm going to share with you several studies. Now, I'll tell you right now that my slides are they absolutely don't follow any of the guidelines for slides for presentation, and the reason for that is because I like to help the people that are in the audience have a reference for the presentation, so you can come back, and you'll note at the bottom of the slides there are references, so you can actually go to the original article and read it for yourself if you like. But I do this purposely, so listen to me and don't try to follow it all on the slides, because you can come back to the slides. So I'm going to be going over several of the studies that I think are informative. This is a nice study performed early in 1999 in 177 getting case management and 186 getting usual care, and this is both post-discharge from hospital. And with an intervention which is 4 weeks, they were able to reduce readmissions, reduce hospital days, readmission costs, and had a reduction in total post-discharge costs from $3,600 for the usual care, for the case management compared to $6,600 for the usual care. So this study really suggests that there could be something in this case management that might work. Let's move forward now to 2012. This is a study by Bazo. This is in homeless population. Again, the complex. Yeah.
What is the multi-domain case management?
I'll get to that. Okay. So that's part of the integrated case management. So we'll come to that. So the cost savings in homeless, and this is comparing 204 to 201. Decrease in hospital days, decrease in ER visits, decrease in residential days, nursing home days, decrease in legal aspects, arrests, jail days, convictions, with a total savings of about $6,300 per case managed. And that's a pretty good reduction to have as good of outcomes as these patients had, or clients had. Now, this is telephonic case management, and a lot of people have reservations about telephonic case management. This is a behavioral health telephonic case management that was done they were published in 2005, and really what it shows is that telephonic case management works as well as face-to-face case management. Intuitively, you wouldn't think so, but in fact, in working at Blue Cross and with a number of other health plans, telephonic case management works really great as long as you're a human being to another human being. I had one case manager when I was at Blue Cross that wanted to fly her out to Seattle, which is where the patient lived, to watch her run a marathon. So they had developed a relationship that she wanted the case manager to. Now that was all telephonic. That was all telephonic. So the point is that in this telephonic case management, you can have the same kind of outcomes, and behavioral health actually has better outcomes if you look at the literature than medical. And part of that is really because the medical typically neglects the behavioral health comorbidity, which plays a huge role in outcomes. And we'll get to that in a minute. So this one shows a reduction in bed days from 771 to 168 in 12 months, with a net savings pre versus post of around 198,000 in a very small population. So there's a great opportunity. Now, the thing that I liked about Taylor's study is that then he or she, I can't remember whether it was a he or a she, but they said, okay, what looked like it worked? What made the difference? And it was the relationship was right at the top of the list. The relationship between the case manager and the client was a huge factor in outcome changing. Communication capability, medical director support. So if somebody is not getting better, what do you do next? And that's where the medical directors come in. And in connecting the various providers, the behavioral health providers, the primary care docs, the insurance company that handles the benefits and things like that. And all of those led to the outcomes. So now we sort of get into, okay, what should we be thinking about as we go into the next period of case managers contributing to health outcomes for patients? And this is where we get into integrated case management. And we'll get into this multi-domain thing, but I want to just give you a line-by-line difference. Traditional case management is typically illness-focused, whereas integrated case management is complexity-focused, and that's multi-domain. And we'll get to what I mean by that in a minute. It's relationship-based, so you don't have a series of staccato questions that you check boxes off. You actually have a dialogue with the patient to come up with where the barriers to improvement are occurring. Now, you still have a grid that you fill out, but that grid will then disentangle all the barriers so you can actually build a care plan based on identified problems for that individual. It's always longitudinal, so you don't just do it in the hospital and when they pass through the discharge doors, you're done. You follow the patient until their health situation is getting better. The multi-domain I'll get to in the next two slides. Few handoffs. So we train case managers to do both the medical and the mental health. And this is the case management training program, which is a national sort of 4 webinars that are 2 or 3 hours long, and a face-to-face training, which is really a critical component to the training. So you learn how to anchor the complexity issues. And this is something that came from 15 years of research in Europe. We imported it, worked with the European researchers in developing it for, our peculiar medical system, and then rolled it out. So it's a biopsychosocial and health system approach. There's an expectation that there's escalation of care if people aren't getting better. So what's the difference between health complexity and illness severity acuity? Well, illness severity and acuity is this biomedical concept where somebody has an illness and it's spinning out of control and it's really causing a lot of problems. It could be bipolar illness or schizophrenia, or it could be kidney failure or tuberculosis or chronic lung disease or what have you. It certainly is a component of complexity. No question about it, and it has to be addressed. And in fact, in the integrated case management approach, it is addressed. But complexity also has the biological, the social. Does anybody have a support system? Do they have a place to live? Do they have insurance? Do their doctors talk to each other? All of those play significant roles in the complexity of the case and need to be addressed by the case manager. So the health complexity is a biopsychosocial and health system approach that leads to improvement. And this is the grid that I was talking about that we use in this integrated case management. It's called the complexity assessment grid. And you can see there are 20 boxes in the grid. These boxes were picked by the European researchers doing standardization and inter-rater reliability and et cetera on the scoring of these grid items in the 20 boxes, and those are all chosen because they are items which predict poor outcomes if not addressed or if there's a problem. So they're sort of like health risk assessments on steroids. Okay, because you not only can do the assessment of this, but you also can build a care plan related to this. And when you do the care plan, each one of those are scored on what we call anchor points. So the anchor points are color-coded, green to red. It's a little bit like a traffic light. So the green says, no problem, forget about it, let's go on. Red means this is a huge problem, you need to take care of it really soon because the person's not going to have a good outcome unless you do. And so you score it based on this, and you have anchor points, so there are specific clinical things you look for in scoring it. And when you've scored it, this is what the grid looks like, and we have an internet-based software program that people can use to actually input this and put clinical notes in and et cetera. So I just wanted, now, you don't have to use this. There are a variety of other documentation approaches that can be used. I told you that I was biased. I think that this is a good approach. I think there are a number of other very good approaches that can be used. But regardless of which approach you use, you really have to, number one, do the assessment. Where are the problems? Connect the problems to the goals and the actions you're going to take to correct the problems, and work with the client or member or patient to achieve the goals that you have for them. So those are critical factors. Now, using this complexity grid, there have been a number of studies in Europe looking at different populations, and you can see there's MS clinics, renal clinics, general medicine clinics, diabetic clinics, and psychiatric consultation, and different clinical locations will have different levels of complexity of the patients that they care for in those settings. And so you can actually predict the number of case managers you might need based on the location that you're focusing on, your target population. Importantly, the majority of mental health problems actually occur in the medical setting. All of the mental health workers in this room are working with the little sliver between the two large ovals, large wide ovals. That's the mental health sector. The pink oval that is intersecting with the large two white ovals is where the vast majority of mental health patients are, and they have no access to mental health care. And if you as case managers don't help them to get that, they aren't going to get it. In fact, there's pretty much a wall between the two. So you have the medical sector on the one side and the mental health sector, and that's what I call throwing over the wall, and they never talk to each other. And what happens when you have comorbid illness? Now, this is a very interesting slide. In my consulting work, I have an opportunity to work with claims databases that are really quite large. And in working with a number of health plans that have these huge claims databases, this represents a consolidation of claims data on about 6 million, representative of 6 million population. So it's a huge group of people. And in this, what I've done is I've shown on the top line, that's all insured. So it's about $3,000 for everybody that's insured. And of that, about 15% will have a mental health comorbidity. But now, if you divide out some of the common chronic medical illnesses, in the second column there you can see that the total cost, annual cost of care about doubles. The total annual cost of now it's doubles or triples or quadruples depending upon which area of chronic illness a person fits into. Most people don't go the next step, and that is, so the third column there is the prevalence of the chronic medical illnesses. So 6.6% have arthritis, 5.9% have asthma in this particular subset of population. The fourth column there is those that have mental health comorbidity along with their chronic medical illness. So it's around somewhere between 30 and 45% will have mental health comorbidity associated with their chronic medical illness. And the more ill they are, the more chronic medical illnesses they have, say they have 2 or 3 medical illnesses, the percentage goes up. the likelihood of having mental health comorbidity. If you then look at the total cost of care, just in that subset with the chronic illness and mental health comorbidity, it doubles again. So this is a subpopulation. It is a huge, huge cost, but they live in a segmented medical world. So they really have no access to getting medical and mental health service in a coordinated fashion. And that's where the case manager comes in. Now, the majority of the spend for patients that have comorbid medical and mental health services is on the medical side. This was actually a study done by Marshall Thomas, who is here in Colorado. He is the CEO for Colorado Access. Now, he used to work for the University of Colorado. What he was able to do is take 6,500 Medicaid patients in your population and subset those into those that had no mental health issues. That's the far right bar, the far left bar. Then those that had any mental health, that's the one that's between the two yellow bars. And then over on the right-hand side, the four bars there are those that had psychotic illness, depression, anxiety, or substance abuse. So you can see the yellow is medical service use, the black is pharmacy use, and the red is mental health or substance abuse use. So the vast majority of the spend for patients that have comorbid mental health and medical problems is for medical and pharmacy services. It's not for mental health services. And yet if their mental health issues got better, the likelihood is, in fact, I'll show you data showing that their medical illnesses get better. And so this integration of services actually turns out to be pretty darned important. Most of the people that have mental health problems in the primary care sector get no treatment at all. That's zero. Remember that Venn diagram that had 80% of mental health care was seen in the medical sector? 60 to 70% of them get no mental health services. Zero. None. 40% get it, but most of them don't get it from people that have good evidence-based practices to help them get better from their mental health problems. Even the primary care docs, and I think that's the next slide. Now, I threw that slide out because Dean Williams said I had too many slides already, so that's why you get the slides and you can take them home. If you compare mental health treatment by the primary care doc to mental health treatment by a mental health professional, it's about 1 in 9 will get evidence-based or outcome-changing care versus about 1 in 2. So outcome-changing care occurs much more likely if provided by a mental health professional. So that would be your inclination as a case manager, is to make sure that somebody is getting to a mental health professional if they have medical illnesses but comorbid mental health problems. Now, case management really has gone through an evolution. In '95, it was really in its infancy, and there were standards that were developed. 2002, an update of the standards added practice locations and performance indicators and skill sets. In 2010, there was another standards published by the Case Management Society of America, which started emphasizing the need for individualized assistance in multiple domains, that is not just medical, but medical, mental health, social, and health system. And for transitions of care to make sure that people that are being discharged from the hospital get good communication between providers and the patient or client gets notified. So this has been an evolutionary process. And now in the 2010 standards, there's an expectation that the case managers will be working with a client-centered approach. So it's holistic and you're collaborating with the client. It's system-centered in that there's access and coordination of care. It's problem-centered so that you're really trying to solve the issues that are leading to poor outcomes. And it's outcome-centered, not process-centered. So it used to be that it's the number of touches or the number of telephone calls you used to make. Now it's actually looking is the clinical condition and the functional condition of the individual you're working with getting better, and that would be an indication of whether you're being successful or not. So this is Palin and Tayens published a major core textbook on case management in 2008, and these are the 6 components of case management. And the asterisk, so it's patient identification, doing a comprehensive assessment, building a care plan, implementing the care plan activities, ongoing evaluations and looking at goals and outcomes, and then patient graduation. And I have asterisks by those because that's where the miracle occurs. Okay? And this is sort of my way of saying, okay, what's this miracle? So this cartoon says, I think you should be a little bit more specific in step 2. It says on the blackboard, and then a miracle occurs, and that's the way you get to the other side of the equation. So what is the miracle that we're talking about? So it's really systematic targeting of complex cases, okay? So it's really identifying those that can benefit the most by the service that you give. It's systematic, multi-domain, that is biopsychosocial and health system, clinical and non-clinical assessments of patients, building a care plan based on those assessments, and then case management time to implement the care plan. So if you have a very needy population, as many county case managers have, they may carry 250 cases, they have no time to work with the cases in a way that would lead to long-term outcome change, which is really what you want. Longitudinal outcome changing, or real-time recording of outcomes, escalation of care, and then graduation as patients or clients get better. So as you work in your system, you should be thinking about, in your system, whether you have these miracle ingredients as you do the PACE or the guided care or the disease management, and et cetera. What kind of training do you have? Most of the case management approaches look at the professional background of the people that are doing the case management, and they say, okay, well, you're a really great social worker. Why don't you do this case management? Oh, by the way, just do whatever you think is good. And there really are some learning things that you need to go through in order to understand how to do case management well. This is absolutely true on the nursing side as well. So case management training, targeting high-risk patients, disaggregating the barriers to improvement, both the clinical and non-clinical, anchoring the care plan goals to the assessment that you did, and then helping and working with both the patient, client, and the clinicians that are working with the patients to make sure that outcomes are occurring and the person is getting better. We really believe strongly in here and now outcome measurement, and so we have it built into our system. Most of you that are working in systems will have some kind of way to document outcomes, but it should not just be whether you have made enough calls or have touched the person enough. It should actually be looking at whether the person is having a better health outcome and functional outcome. So other helpful case management characteristics, things that allow you to determine what's a reasonable caseload for you to have, defining what a comprehensive assessment is. I mean, do you cover all of the social or health system? Do you find out whether the docs are talking to each other? Do you find out whether the person actually has trust for their clinicians and will follow through on the recommendations that they have, and things of that nature? Address non-clinical barriers just as often or as seriously as clinical. Connect the barriers to goals and actions. And goals are where you want to be. Actions are how you get there. So a lot of times when you're building your care plan, a lot of times case managers have difficulty in determining what's a goal and what's an action. And so goals are where you want to be. So it's understanding their illness. That would be a goal. Action would be providing educational materials. Okay? You see the distinction? So it's important to understand that, because when you do your follow-up assessment, you want to see whether you've gotten to the goal. You don't want to know that just did the action. You want to see whether the patient actually does understand their illness better. So connects barriers, determines readiness for change, outcome measurement, and then we think that a pediatric component is an important component for a subset of the population that is needy as well and is not adequately addressed. Now, we're just starting to get evidence related to the integrated case management. There was an early adopter, a health plan in New York that is a Medicaid health plan that really treats the worst of the worst on the streets in New York, and they call it feet on the street case management because they actually have to go out and find them and personally, develop a relationship and make sure that they can get back to wherever they're living. But they've really been able to, in a very small number of patients, demonstrate huge savings for the state of New York. Now, this is supported by a grant in the state of New York for the patients that they worked with in this case management in pre and post. Now, this is still early, so we don't have good solid data like the studies that I showed you for some of the other approaches that have a lot more studies related to them at this point. This is a time of health reform. Some of you will be aware that CMS in the Affordable Care Act has a section 2703 which does endorse the development of case management as a service to populations, mainly in the public programs. This is a huge opportunity. Now, we're just getting into these exchanges and implementing the health reform and all this kind of stuff. So you probably haven't seen it on the street yet, but this is going to be a way in which the payers support case management in the future. And one of the things that you as social workers have to do is to start developing those skills, because you will have a huge role to play in supporting these needy patients with a variety of backgrounds, but probably mostly coming from public program situations to allow them to get better. The clinicians just don't have time. The clinicians are already, there are a couple of studies showing that a clinician, if they did preventive care, acute care, and chronic care, they would have 150% time commitment to an average population of patients covered. They just don't have the time to do the things that you can do with a subset of the population. So if there is an opportunity, it's time to accept that, and it's time to get rid of this old, outdated thought that only nurses can do medical case management and only social workers can do behavioral case management. Because again, it's not treatment, it is supporting patients that are having health-related problems get the kind of care and support that they need to reverse the barriers to improvement. And that doesn't take, treatment or intervention, it takes assistance. One of the places that you shine is in the listening. Motivational interviewing is a huge component of case management. You're not going to change the patient. The patient is going to, or the client is going to change themselves. So you have to use motivational interviewing techniques to allow them to see what might work for them. And that's one of the things that nurses have a little bit more challenge in doing. Now, many of them do it very well. I'm a doc, and we do it terribly. So we really have to, do our homework and start doing it better. Training in cross-disciplinary service, and that's really a stretch for most people. People that come from mental health backgrounds are really worried about doing things on the medical side and vice versa. There's really no magic on either side. I've practiced both sides, and I've actually trained social workers and nurses on both sides, and it takes about 3 months for you to get the basics and working with them. And I typically work in pods, so there are people that come from medical backgrounds and mental health backgrounds working together to cross-fertilize, and in about 3 months you sort of get comfortable with the usual things. In about 6 months you're comfortable and you're ready to go with the usual things, and you're sort of ready to start the less common things. And in a year you're feeling pretty proud of yourself and saying you can do things other people can't do. Regardless of how good you are, you always ask questions. There's always things you don't know. And, I'm boarded in 2 specialties. I still ask my colleagues when a bad liver disease problem comes up, or, eating disorder patient has problems, or what have you. So you always have to go to team members to get assistance. Working in pods helps, and then changing the process to outcomes rather than processes. So transitioning is a challenge, and there are a number of things that you need to do: the acculturation, the staff training, the organizational realignment, and outcome orientation are all things that fit into that. I'm not going to spend a slide on acculturation, but that's a huge thing. We have not, medical people and mental health people have not practiced or worked together for so long that they no longer feel comfortable in talking to each other and working in their cross-disciplinary settings. And this is one of the challenges that the integration has. Just putting mental health people into a primary care setting doesn't work. You have to have mental health people that are actually actively working with the medical people. So it's really an acculturation problem in addition to a moving to different locations. The training is really very important. Basic case management has motivational interviewing and care plan development. Cross-disciplinary training is becoming more popular. I would suggest that there's some additions to that we really need to move into, because you really need to make sure that people are getting outcome-changing care. And in interviewing and management technology, what kind of software you use, whether it's cross-disciplinary software. There's just a recent study showing that electronic health records in which all clinicians have access to both medical and mental health have lower readmission rates at 7 days, 14 days, and 30 days. And this is in like 18 large academic medical centers. So communication, documentation systems that communicate with each other are absolutely important. And it means that privacy is important on both the medical side and the mental health side. If it's not good enough on the medical side, then you bolster it. But you don't not do the mental health with the medical. Organizational realignment. Now, this is something that is the integration part of it. It's putting the mental health with the medical, or the medical with the mental health. There's a very nice demonstration project out in Cortez. If you want to go out there and visit it, it's part of the ACT program. That's a Colorado-based grant process. A mental health center has brought in family practitioners and pediatricians into their, so they have integrated care, but it's starting from the mental health side. Strange concept, but it's working pretty well. So there's a variety, but you have to, co-location is critical, but it's not sufficient. The mental health people and the medical people really have to actively work with each other. And there's accountability. Now, this is a way too busy slide, and this is one of the slides you'll come back to if you have any interest in looking the handout that was given to you. But it is sort of the pathway that you go through with case management. The triage is where you find the complex patient, and that really comes from either your EHR registries, or it comes from talking to the docs and the nurses and the social workers that are working with the patients. They can find the heart sync patients in a heartbeat just looking at the stacks, or the claims databases if you work for a health plan. So once you've triaged to a subset of the total population, that 5 to 7% that has the greatest need, then you find out who's willing to work with you as a case manager, and you do your assessment, and then you manage. And now nobody wants to be managed. You work with the client or the patient in overcoming the barriers to improvement. And that's an iterative process that happens over weeks to months. And in some situations, patients are just so needy that they need to be followed longitudinally for years. And that's one of the things that's going on in New York with the population on the streets of New York City. So challenges, transitioning work processes, dismantling the disintegrated clinical services. We certainly have done a very good job of separating medical from mental health. That has to go away. And moving to an outcome orientation, and outcomes are clinical, functional, cost, and clinical and satisfaction, quality of life. Gosh. Okay. So the messages are case management for complex patients could be a major contributor to the triple aim. You are front and center in that. How case management is delivered is core to the value, though. So what you do as you do your case management does make a huge difference as to whether you're going to create a health outcome, which comes first, but also an economic outcome. And so if you're going to do something to start with, they're just as well hit the group that you know that you can do the best for, and also you can save money. Because then as you save money, then you can expand your program. So you can sort of spread out the resources. So social work and nursing have central roles in this, and Case Management Society of America has been a nursing, largely regulated organization. They are now in the process of looking at adding social workers to the leadership. That is certainly an ongoing conversations. They clearly recognize that social work plays a significant role in the future. And so I guess I would encourage you to not be feeling like you're going to be left out, because I think that you will play a significant role. So I come back to what I started with. Your role in the next generation is develop the vision and create the future. Now this has to do not only with those that are on the front line and working with clients or patients or members or employees or enrollees. It also has to do with the administrators and department chairs, because as a part of that, you have the big picture. You not only have to provide the clinical services, but you have to have the pipeline that's creating the people that are going to fit into this. And so that's education and training, it's research, what works and what doesn't, and it's administrative reorganization. What do you have to do to make this work? And I'm going to stop there. This is the book that we wrote on integrated case management. It's a resource. I've also listed the training program. Now, if you're using a case management approach that is working for you, that's great. But you need to make sure that you're using the components in your program that are going to lead to outcome change. With that, I'll stop and answer any questions that you might have. Thank you. Yep.
So on the healthcare reform opportunity slide, I've heard differing what that money's going to pay for and how you sign up. Do we know yet what that's going to look like?
No, we don't know. There are a number of innovation grants that have gone in, that some of them bundle payment for case managers as a part of, a little bit like they bundle services in hospitals on different units. There's that component of it, and nationally there was not the interest in moving to codes for case management. This year I think they're going to be looking into codes for case management. Now it's interesting because all the coding for the fee-for-service arrangement is face-to-face, and what do case managers do? They call the community resources, they call the docs, they call the family, they work with everybody else, including the client. But if they can only bill for working with the client, that's counterproductive, okay? And so that has to be looked at in a little different way than most of the fee-for-service coding arrangements will go in the future. My personal feeling is that case management should be a bundled service, so that it would be, you have your population, and a percent of that population is going to fall into this complex category that has special needs, and that case managers will be identified to work with those clients that are willing to work with the case managers. And because really, you don't want to be tied to the encounter. I mean, docs right now with a fee-for-service is stupid, are tied to the encounter. So if I want to do a test on a patient, a blood test or an x-ray or something, I do it. I can't call them and say, everything's normal. I have to have them come back to my office for 3 minutes. They leave work or leave their family or what have you, so that I can get paid to tell them that the test is normal. That's stupid. So I think that bundled services, I think we're going to be going to that, and that's where these ACOs or clinically integrated networks come into play. We will be moving to that. That's a gradual process. Colorado actually has a pretty interesting way of doing the RICOs, the ACOs. It's promising, I guess is the best way to put it. But I think case management would fit into that category. Yeah.
Similar to that, there's also a lot of uncertainty about where case management may be housed.
Mm-hmm.
Whether it's the primary care office, maybe the mental health center, other community-based agencies. From your knowledge, do you have any ideas of where the funding may go? Is it going to be open so it's the best place for the client? Or?
Yeah, that's anybody's guess. My personal opinion is that the medical and the mental health funding pools need to be coalesced into one pool, okay? I can tell you right now that the managed behavioral health companies are going to fight that till they die, and hopefully they will die. Now, there are a lot of good people, don't get me wrong, there are a lot of good people in the managed behavioral health industry that are trying to support good mental health care. It's just that they have a model that doesn't work for the vast majority of people that have mental health problems. And so it really has to be changed. And that's a challenge. We have challenge with, the practitioners choosing to do integrated service delivery. So in the transition period, it will be everywhere. So it could be in the medical setting, it could be in the community mental health centers, it could be telephonic, so that they would be working with both. It could be that the case managers will bounce, so they'll be in the medical clinic one day and the mental health the next day. There are a variety of models. Some are better than others, but each one of them are customized based on sort of the needs and the personnel they have available and the like. Yeah, sure.
Do you see, has there been examples or potentials of some of the community social service agencies that are doing case management but not necessarily tied to physical health or mental health care settings? Do they need a partner, or do they need to rethink about where their case management services are going?
Yeah, there's a lot going on in Colorado. Okay, Colorado is you should be proud. Colorado is a very progressive state, and it's doing a lot of good things. There are a number of case management organizations, I think HealthWorks, Health Teamworks or Health One. Okay, so that are moving to an integrated model. But then where do you put them? How do you use them? For whom? And all of those are sort of things that we were talking about today. And there are a lot of different opinions on how that should work. So I think that we have to work through that. And that's one of the reasons why we think that there's a need for communication of the different approaches that are taken, because there are obviously a lot of people doing very good approaches currently. A lot of them are idiosyncratic. I mean, they figured out what works for them and they use it, and it's like the things that everybody should be doing. But then there are people that are going by the letter of the law of the particular approach and forgetting that there's a patient at the other end or a client at the other end that needs to have an health outcome. And so you really have to adapt it to the setting. Yes, in Colorado there's actually some interesting things going on, so I think you have some opportunities here. Yeah.
So going along with that.
Yep.
Even at where these discussions are happening about what it's going to look like coming down, are there small social service agencies involved in those conversations, or is it major medical, mental health, those big agencies that are in the conversation?
Yeah, all of the above. Yeah, it can come from the bottom up, it can come from the top down, it can come from individual case managers. I work with a number of individual case managers that are contracting their services to hospitals at discharge or to employers that have problem employees or employees that have complex health issues and doing it individually. There's other large health organizations that have case managers embedded. Oftentimes those are telephonic case managers, and a lot of the clinicians in the room will say, well, how can that work? You have to have a person-to-person. In fact, over the phone, and I've watched it happen with my case managers, over the phone, a relationship can develop, and it's amazing. Some patients actually like the anonymity of the telephone. They don't like to have that face-to-face and admit that they, did thus and so. And so the telephone offers that opportunity. My personal feeling is it's a balance. There's some real value to having face-to-face, but you can also do follow-ups with telephonic. So it's a balance. Yep.
I just had a question about one of the studies that you mentioned where there was no reduction in mortality or the expenditures. Was that a non-integrated case management model? That was studied there?
Yeah. Now that was the review of this 109 randomized controlled trials performed over the past 20 years, and it was selectively only for medical case management, outpatient. Okay, so it did a PubMed search on the world literature on case management, limited to English, so it didn't even include the studies in Japanese and Portuguese and et cetera, and it didn't look at longitudinal, which is a really hardy component of outcome change. If you just do cross-sectional, you can get some outcome, particularly like discharge management is a common kind of case management where somebody's discharged, and so the case manager's role is to make 3 calls. The day after discharge, and then a week or 2 later to make sure that the person filled their prescription, saw their doctor, and is taking their medicine. And once that's done, they've fulfilled the requirement of case management. That will have a short term, and it does decrease readmissions, but it isn't going to overall change the trajectory of the health issues of the individual. And that's what this study was looking at, the long-term health trajectory. And so it was a review of randomized controlled trials. So it wasn't a specific study. Okay? Yes?
Well, I was wondering about the trends you're seeing in your organization. You mentioned 85% of the organization is nurses, 15% social workers, and you talked about incorporating more social workers into that. And I guess I keep thinking about social workers training, and we have such an identity in terms of social work and some of our values that we stand for. And even in the hospital that we work out, that transition has been somewhat challenging in terms of we still call ourselves social workers and don't really want to call ourselves case managers. I just wonder what your thoughts are on that, because it's been quite a challenge in our hospital.
Yep, change is tough. Change is tough. Nurses, actually, in nursing, case management isn't even really recognized as a subspecialty in nursing at this point, even though there are really a large number of nurses that are doing it. You should know that the CMSA offices in Washington, D.C. are in the National Association of Social Work, so they are co-housed in Washington, and they're communicating regularly at this point and looking for ways. As you take on new opportunities moving forward, you will maintain your social work identity. In fact, you have some skills that you will be able to teach the nurses as far as identifying resources that the clients may be able to access, and interacting with people and et cetera. They, on the other hand, will help you to understand the illnesses that you may not work with as often. Now, I have to tell you that I had a social worker. Well, I had 2 social workers. I ran a med psych unit for 15 years at the University of Iowa, and my social worker could do medical and mental health social work phenomenally. I mean, she was a wonder. And so she could find places and support people and families, and it's all the things that the good work that you guys do. But you just have to translate that now into this different arena, and then become involved in it. But it does mean that you're going to have to identify as a case manager.
What was the name of the CMS? You mentioned 2703 that specifies the case management? Did I get that
right? Yeah, Section 2703. Yeah. Yep.
Have you found any backlash from nurses about having social workers get back into this? Because I'm wondering how that is, state from state. Because sometimes I think there can be competition from for jobs and looking at. I mean, I know here in Colorado, a lot of jobs state that they really prefer a and being able to be labs.
Yep. Right. So yes, absolutely. The nurses say, well, social workers don't have a medical background. Well, doctors say that nurses don't have a medical background. Doctors and nurses don't get along together either, but we have to learn to work together in the same sandbox. And the need for this population of patient is so great, and the opportunity to bring value to patients, health, function, and oh, by the way, not so much out-of-pocket expenses for your health care, is a huge contribution. And I think that we need to recognize that there are some credentials that are needed to fall into the case management arena. So that you have to be accredited, training in social work and have certain kind of credentials that will allow you to do, the basic kind of things that you really need to be able to do. But then you have to start talking about, well, how can we work together to help each other out, do good for the people we work with?
Sorry, I just talked to one more question. So, in the care management that we provided, we work with the chronic illness population, and in our outcome study, we found that we really didn't impact their chronic illness so much, but we did impact other aspects of their life. So it may not really reduce the amount of medical care they seek because we can't change the way their body has this illness, but we can change the way they access other social services and other care. So in the outcomes measures, is that a piece that's looked at, or is it only looking at the reduction of medical costs and the access of the health plan?
Right. Well, this gets into the bean counters. Okay, the bean counters are interested in how much you save. And you're absolutely right. You bring a tremendous amount of value, maybe not cost savings, to a variety of the people you work with. When I run the numbers, and I run the numbers pretty regularly in my consulting work on how much it costs for a case manager, the cost of salary and administrative infrastructure and things like that, and the cost of the patients, the subset of patients that is using so much services. So if a case manager only changes outcomes in 6%, he or she has more than recouped the cost of their salary and savings to the system. So if you bring, non-economic value to, 6 or 7 of the 10 that you work with, and economic value only to 1, you've still made your salary. You're still golden. But if you don't bring any, so that you're an expense, then they're going to say in year 2 and year 3, well, how good was this program? Can we continue to support it? So you'd like to put it together in a way that you can do both, that you can bring value, clinical value to your patients or clients, and also, to the extent you can, decrease cost. Because that's the way you're going to continue to support the case management approach to patients in the future. Did that make sense?
I was going to ask that. As a school of social work, we're really about sort of workforce development. And it sounded like that with this new Affordable Care Act, there's going to be a need for social workers to be trained to be able to work in these sort of integrated, interdisciplinary types of areas. So give me your top 5 hit list of things we should be doing here at the School of Social Work in our curriculum to train our students as practitioners to really sort of grab these jobs, be successful at these jobs.
Yeah. So I can tell you right now that social workers are the first line professionals to be asked to go into integrated primary care offices. And that's nationally, is not just here in Colorado. It's certainly true in Colorado. But nationally, social workers are the first line people to go in. And part of that is because you're the least expensive. You're not as expensive as psychologists or psychiatrists or nurses.
We want to change that as well.
Absolutely, and I'm not saying, but what they do then is they have you come in and they say, okay, you're responsible for the mental health of our primary care patients. Do it. Well, it's a group of 4 docs, 10,000 patients, and there's one social worker there, and they, how does one social worker do that kind of arrangement? So helping social workers to learn how to work as a part of mental health teams that would go into an integrated setting. So it would be developing relationships with nurses and with psychiatrists and with psychologists and with primary care to come in and work as teams to support that 80% that are getting no care currently. And frankly, the social workers are some of the most important people, because a lot of them really need not the interventions, but also the identification of where the community resources are, support for family, and all those kind of things that you have special skills at. And you would want to then capture some of the others to do some of the other things that they have special talents in. So it's learning to work in teams in integrated setting. The other thing you're already doing is you're starting to work in integrated settings in some of the projects that your faculty are doing. And I think that is definitely in the future where we're going to be going. The slides that I showed you about how much it costs not to is so great that we really have to move in that direction.
If it's okay, I'm going to take the last question. I think one of the areas where, from what I know nationally is going on in sort of the trends in social work education, healthcare, and especially that sort of what I call the duel that's going on between nurses and social workers, is that nurses sort of are beginning to train themselves so that they're able to work on the clinical side and the non-clinical side that you showed up there.
Mm-hmm.
I think we're social workers, we still have a challenge that we're really doing a great job of training our practitioners to work on the non-clinical side, but most of them don't have a lot of information of how to be sort of successful or contribute on the clinical side. Mm-hmm. And I think that's a challenge, and this is not a question, I think that's a challenge just as a profession, to really sort of to put more in our curriculum so that our graduates feel comfortable on the clinical side. We're not trying to make them junior physicians, but at least they have enough information so that they can feel that they have a sense of a contribution on both sides. And I think that's where the nurses have done a very great job of having information on both sides of those lists that you put.
Yeah, and I think you're right on target. I think you don't have to know how to treat, but you have to know, the way that I look at it, it's case management is sort of like, you're a son of a parent that's having difficulty, and you're an advocate for that parent. And you don't have knowledge about all the, the illnesses and all the things, but you learn enough about that to make sure that your parent is seeing the doctor often enough, basically getting the tests that they need to have, getting follow-up that they need to have. That's the kind of thing that the social worker does and the nurse case manager does. You don't have to have in-depth medical knowledge, but you have to have a basic understanding of the illnesses that you work with. And both on the medical and the mental health side, there are a list of common conditions that if you know those, then you can ask people about the other less common things. But getting that basic information is where I think the School of Social Services could help their students in developing some core skills.
Thank you very much.
Thank you very much.